Hi everyone, this is Dr. Sandy, certified bariatric surgeon, and today we are going to perform a gastric bypass. So first I would like to introduce all the members of our team. First of all is Dr. Christian Rodriguez, as well certified bariatric surgeon. So this can give you the confidence that there are two bariatric surgeons in our team. We have Dr. Esperanza Escobosa. She is our anesthesiologist, expert in this field. We have as well Dr. Veronica Cubillas. She is our surgical assistant. And here in the OR as well is our registered nurse, Enrique, and he will be with you all through the process before, during, and after surgery. So we are going to start our surgery. We have a female patient. She is 45 years old, and in this case we have a BMI of 36. Why did we decide on doing a gastric bypass? Well, this is because she has diabetes, hypertension, and she has severe acid reflux. So all of this tells us that we should perform a gastric bypass instead of a gastric sleeve. We are now insufflating the cavity. This is so we are able to perform the surgery. We will put air inside her abdomen so we are able to see and to introduce all the instruments. We introduce from 1, in case of the single incision, to 5 trocars so we are able to perform the surgery. We will do incisions from ½ centimeter to 1 centimeter. We are now introducing the trocars. Here we have already introduced one of ½ centimeter. We have one of 1 centimeter, and the rest of the incisions will be ½ centimeter. Depending on the liver size, we always decide if we need or not the liver retractor. In this case, the liver is big, so we will introduce a liver retractor to be able to perform with more safety the surgery. It is a very small incision, so there should be no scarring after collocating the liver retractor. It is very important that you know that in our team we have 2 certified bariatric surgeons. So this will give you the safety. There are double the chances that everything will be good and smooth during your surgery. So right now we are going to start surgery. We have to liberate the stomach from the fatty tissue to be able to perform the gastric pouch. To be able to have a smaller pouch, a cleaner pouch, we perform a partial gastrectomy. What does that mean? That we remove a small part of the stomach. Of course, if you do not want us to remove any part of your stomach, we have the option of performing without removing any part of your stomach. Some patients before surgery tell me they don't want any part of the stomach removed. We can do that as well. There's no problem. In this case, the patient did not refuse from the partial gastrectomy, so we will remove a part of her stomach to be able to do a smaller pouch. We take our time to do everything in the best way. We have our anesthesiologist monitoring you all the way through the surgery. She is expert in obese patients and has more than 8 years of experience in bariatric field. Our surgical assistant, Veronica Cubillas, she is a doctor. Sometimes some teams have nurses or people that are just qualified in this area. Well, we have a doctor with us, and she has as well a lot of experience assisting bariatric surgeries, and as you will see through the surgery, I don't have to say a word to her, and she already knows what we need. This patient comes all the way through Canada to come here to Mexico to perform surgery. She has heard a lot of good reviews about Tijuana, about what we are doing here in Mexico, and of course of our hospital, of our team staff. So she decided to make all that trip just to come with us. So right now we are going to start to confection the gastric pouch, and we use stapler devices to be able to staple the stomach and to cut it. We use Covidian staplers that gives you the security that everything will be as best as possible. We will now introduce the boogie, that is a device that helps us calibrate the gastric pouch. So all the pouches are the same size and we have consistency in our procedures. As you can see in our surgeries, there is little to no blood because we do everything carefully and we want the best for you, the best recovery. So everything is as clean as possible. Right now we have finished to confection the gastric pouch and we will reinforce the staple line with a suture. We always reinforce our surgeries, the gastric sleeve and the gastric bypass, duodenal switch. All our surgeries are reinforced because this helps us have less probabilities of a bleeding after surgery. Reinforcing the suture line, we can see that there is less chances of having a leak. So this is why it's very important to reinforce all our suture lines. Coming to Mexico can be very scary, I know, because of all the things that they say about us in the United States and in other parts of the world. But I can assure you, all of our patients, as soon as they arrive here, have a very pleasant surprise, knowing our facilities, knowing our staff members, getting to know that everything is first class over here. So feel confident that this is the best option for you. So right now we have finished to reinforce the gastric pouch, and we will now reinforce the remnant stomach. That is a part of the stomach that won't have touch with the food or with the liquids. Now we are reinforcing the stomach that won't have contact with any food, with any liquids, but it is a part that can bleed, that can have some other trouble, so that's why we take the time and the importance of reinforcing as well this part of the stomach. It is very important that you know that right now, after a gastric bypass, you will have a very, very small stomach that is now called a gastric pouch. This part of the stomach will continue to produce acid and the same substance that it produces before. So after a gastric bypass, you will need to be taking antacids during 6 months until your new stomach is getting used to the new process. So this is very important, and as well as you know, the gastric bypass is a malabsorptive procedure where we will need to be taking vitamins and minerals after surgery to complete all the requirements that our body has. So right now we have finished to reinforce all the staple lines, and we will proceed to do a small incision in the gastric pouch to open and to be able to connect the part of the bowel. So as soon as we finish confectioning the gastric pouch, we will count the intestines, and depending on the BMI and on the chronic diseases of our patient, we decide how much part of the bowel we skip so it doesn't have contact with the food and with the liquids. We should remember that this is a malabsorptive procedure, so besides having certain restriction, because now the stomach is very small, we have the component where there is malabsorption and we don't absorb as much as we absorbed previously. In this case, we have a patient that doesn't have a high BMI. It's more because of her chronic diseases and her acid reflux. We have to separate the fatty tissue so the bowel goes up to the pouch in better conditions. We don't take any fatty tissue out of your cavity. Just so you know, we just separate it so the bowel goes up in an easy way and with no tension. This is important because our anastomosis, where we connect the pouch with the intestines, with the bowel, we don't want it with tension. So we have to separate the fatty tissue so it doesn't have tension and everything